Hi, I'm Nicholas Andrade with Nightingale College, and this is my presentation on post-traumatic stress disorder. In this presentation, I will be teaching nursing students about post-traumatic stress disorder, or PTSD. I intend to teach my fellow students about this mental health condition through the next few slides, including the definition of PTSD and the DSM-5 diagnosis, how PTSD manifests, a little bit about the history of PTSD, some of the ways in which PTSD impacts external factors, the teams that focus on treating PTSD, healthcare practices around this topic, and some of the challenges associated with PTSD. I selected PTSD because it's an important topic to me that I have firsthand experience with. I had a grandfather who suffered from this condition due to his time spent in the Vietnam War. During his generation, the effects of PTSD were still not fully understood, nor were they considered a mental health condition. My intention with researching PTSD is expanding on my own education about the trauma-informed communication, screening skills, and my ability to support treating patients experiencing PTSD symptoms while implementing these care techniques into my future practices. I hope to shed light on this topic with my fellow learners and provide information that can be carried into their nursing practices. The Diagnostic and Statistical Manual of Mental Disorders is the latest edition of the American Psychiatric Association's professional reference book on mental health and brain conditions. The latest version, known as the DSM-5, was published in 2022 and had updates which included a new category for trauma and stressor-related disorders. Trauma and stress-related disorders are rooted in stress, which can be conceptualized as a process with physical, psychological, behavioral, and cognitive components in response to an individual's perception of the physical, environmental, and psychosocial demands placed on the individual. PTSD is a mental health condition that is fundamentally different from physical illnesses because it is an invisible injury rooted in trauma-related changes in the brain, stress response systems, and cognition. PTSD does not present with outward physical signs, which makes it difficult to identify, diagnose, and treat. Post-traumatic stress disorder, or PTSD, is a mental health condition that's caused by an extremely stressful or terrifying event, either being part of it or witnessing it. Specific examples of trauma include physical abuse, torture or kidnapping, sexual assault, natural disaster, accidents, and crime-related and terrorist events. PTSD can also occur in people who have witnessed an unbearable event, such as a first responder answering a call to a violent incident. PTSD is a mental health condition that is often associated with military and service members, but can impact anyone who has been subjected to extreme trauma or stress. The diagnosis of post-traumatic stress disorder and its deleterious effects have received increased awareness over the past decade related to the large number of military personnel exposed to war. However, PTSD is not limited to military personnel. It can occur in any individual who is exposed to trauma severe enough to be outside the range of normal human experience. The common element in all these experiences is the individual's feelings of extraordinary helplessness or powerlessness in the face of overwhelming circumstances. The response to the traumatic event may start within the first 3 months after exposure or witnessing the traumatic event, although symptoms may not appear until years after the event. PTSD symptoms last more than 1 month and can cause impactful and debilitating symptoms, which may affect an individual's ability to perform usual daily tasks, including social and work situations. The U.S. Department of Veteran Affairs have dedicated resources to educate service members and civilians about the impacts of PTSD. The VA has summarized the DSM-5's criteria for diagnosing PTSD as follows. Criteria A. One of these is required. The person was exposed to death, threatened death, actual or threatened serious injury, or actual or threatened sexual violence in the following ways: through direct exposure, witnessing the trauma, learning that the trauma happened to a close relative or close friend, indirect exposure to adversive details of the trauma, usually in the course of professional duties such as first responders or medics. The second criteria is criteria B. The traumatic event is persistently re-experienced in the following ways: unwanted, upsetting memories, nightmares, flashbacks, emotional distress after exposure to traumatic reminders, or physical reactivity after exposure to traumatic reminders. Criterion C requires one of the following: avoidance of trauma-related stimuli after the trauma in the following ways: trauma-related thoughts or feelings, trauma-related reminders. Criterion D to be diagnosed with PTSD is that you have to have two of the following: negative thoughts or feelings that began or worsened after the trauma in the following ways: the inability to recall key features of the trauma, overly negative thoughts and assumptions about oneself or the world, exaggerated blame of self or others for causing the trauma, negative effects, decreased interest in activities, feeling isolated, or difficulty experiencing positive effect. Criterion E requires two of the following: trauma-related arousal and reactivity that began or worsened after the trauma in the following ways: irritability or aggression, risky or destructive behaviors, hypervigilance, heightened startled reaction, difficulty concentrating, difficulty sleeping. Criterion F and Criterion G are both required. The symptom must last for more than 1 month, and the symptoms must create distress or functional impairments, whether it be social, occupational, or work-related. Criterion H is also required, that the symptoms are not due to medication, substance use, or other illnesses. If a patient meets all of these criteria, then they would qualify for the diagnosis of PTSD. There are two additional specifications that are required when diagnosing PTSD. There has to be a dissociative specification, so in addition to meeting criteria for the diagnosis, an individual experiences high levels of either of the following in reaction to the trauma. They would have depersonalization, or an experience of being an outside observer of or a detached from oneself. So people that state statements such as, "This is not happening to me," or if they feel like they're in a dream. The other one is derealization, so the experience of unreality, distance, or distortion. So patients that say things are not real. The second criteria is delayed specification, that this must not happen until at least 6 months, but sometimes the symptoms may occur between 1 and 3 months, and it must be ongoing for over a month. In 2013, the American Psychiatric Association revised the PTSD diagnosis criteria in the 5th edition of the Diagnostic and Statistical Manual of Mental Disorders, or the DSM-5. PTSD was included in a new category in the DSM-5, which is the trauma and stressor-related disorders. All conditions included in this classification require exposure to a traumatic or stressful event as a diagnostic criterion. But PTSD has had a long-standing history rooted in psychology. In the 17th to 19th century, physicians observed and noted symptoms of PTSD, but did not yet frame it as a mental illness as we do in modern medicine. Physicians observe sadness, sleep disruption, and anxiety, but consider them temporary or even cowardly. By the 19th century, as industrial technology advanced, people began experiencing unfamiliar injuries and stress reactions. While these symptoms were originally documented in soldiers returning from war through the 19th century, some of the important developments include recognizing trauma in civilians, the emergence of psychological theories with unexplained physical symptoms, and a growing tension between neurological and psychological explanations. One quote states that during World War I, many soldiers began exhibiting severe psychological symptoms despite the absence of visible injuries. At this time, these symptoms were thought to be caused by physical trauma from nearby explosions. This led to the term shell shock. During World War II, the term battle fatigue was coined, and there was a major shift in psychological analysis to evolve into the basis and framework for modern-day trauma. By the Vietnam War, the shift in psychiatry had focused on trauma and considered it as part of a mental health condition, warranting its own distinct diagnostic category. PTSD was officially recognized as a formal diagnosis by the American Psychiatric Association in 1980 when it was published in the DSM-3. There are socio-economical factors that can contribute to the prevalence of PTSD within a community or population. While personal, familial, social, and cultural factors can be a positive resource contributing to safety and well being, they can also be a basis for placing the person, group, or entire community or population in harm's way or at heightened risk of developing PTSD. The impact of PTSD and psychological trauma can differ depending on individuals' social and cultural context, as well as the resources available to individuals, families, and communities. Similar to many trauma and stress-related disorders, disadvantaged persons and communities, such as those in poverty or who face stigma and discrimination, disabilities, homelessness, political repression, communal and societal violence, forced immigration, interrogation and torture, terrorism, genocide, and catastrophic disasters, are more vulnerable to traumatic stressors that contribute to developing PTSD. Populations that are subjected to political violence, including terrorism, forced immigration, and/or genocide, are extremely vulnerable to developing PTSD. Without access to self-determination and the resources necessary to sustain independence, people are vulnerable not just to traumatic exploitation and violence, but also to the traumatic loss of their intimate relationships, their families, their way of life, and their values. It is estimated that refugees and internally displaced or stateless persons are between 10 and 30 times more likely than others to develop PTSD. Every individual has a unique and distinctive blend of ethnic, cultural, racial, personal, and national characteristics which is unique to them and their identity that may impact their disposition to PTSD. There is a correlation between ethnic background and education on the prevalence of PTSD. However, it is hard to associate this directly with PTSD due to the research that was available. Latino and African American backgrounds and demographics often had higher exposure to poverty and lower education rates, so the higher rate of PTSD that they experience cannot be independently determined due to these correlating factors. Although Latinos and African American persons are at greater risk than European Americans for PTSD, based on the available research findings, it is possible that elevated prevalence may also be due to differences in the extent or types of exposure to psychological trauma, or to differences in exposure to other risk or protective factors, such as poverty, education, or gender-based violence. While PTSD prevalence and symptom severity vary significantly across geographical regions and topographical environments, the differences are shaped by exposure to conflict, access to healthcare, cultural norms, and environmental stressors and population displacement. In 2026, there is a high prevalence of PTSD in areas that are in active conflict. Regions experiencing active war or political violence have dramatically higher PTSD rates. Populations in areas such as Syria, Ukraine, Sudan, and Afghanistan experience repeated exposure to trauma, displacement, and loss. As previously mentioned, refugees and stateless people are 10 to 30 times more likely to develop PTSD, and refugees traveling through dangerous migration corridors face trauma, violence, and instability. Topographical factors that influence trauma exposure and PTSD risk are found in regions that are prone to natural disasters. Earthquake zones, hurricane-prone areas, and wildfire regions are all examples of topographical factors that have higher risk of populations developing PTSD due to natural disasters. Additionally, urban areas with higher risk of crime also have higher prevalence of PTSD due to exposure to traumatic events when compared to rural areas with lower crime. The main treatment of PTSD is talk therapy, also known as psychotherapy, which can help patients to deal with their diagnosis by teaching them skills to manage their symptoms, helping them to have better coping mechanisms, and how to address correlated problems such as depression, anxiety, or substance abuse. Of the 550 randomized controlled trials of treatment methods published from 1988 to April 1st of 2024, psychotherapy interventions were the most commonly employed. Next was the pharmacotherapy and non-pharmacologic cognitive interventions. The two types of psychotherapy that are used to treat PTSD are exposure therapy and cognitive therapy. Exposure therapy helps patients to face situations and memories that may represent triggers for PTSD so that patients can learn to cope with them. This treatment is done in a gradual, predictable, and controllable manner by working with a specialist. This form of treatment is particularly helpful in patients experiencing flashbacks and nightmares. While cognitive therapy is a psychotherapy that helps the patient to see ways of thinking that are keeping them stuck by recognizing their cognitive patterns. By recognizing cognitive patterns such as self-doubt or negative self-views, individuals with PTSD can start to move past their diagnosis and begin to heal. Pharmacologic interventions often include treating coexisting mental health issues that patients with PTSD often experience, such as depression and anxiety. Antidepressants can ease symptoms associated with PTSD-related depression, such as sleep problems and concentration issues. Selective serotonin reuptake inhibitors, or SSRIs, are also used to treat secondary diagnosis associated with PTSD. While anti-anxiety medications can be used, they are generally only used for a short period of time. The nurse plays an essential role in caring for patients with PTSD. The nurse supports patients through trauma-informed care, assisting with coordinating interdisciplinary treatment teams and promoting long-term recovery. PTSD nursing requires clinical judgment, emotional intelligence, and consistent application of evidence-based interventions. The nurse should always use active listening techniques and encourage the patient to express feelings in a safe and controlled manner. This will allow the nurse to identify cues and potential triggers that can set off a PTSD crisis. The nurse's priority is patient safety and crisis prevention. All patients need to be screened for suicidal ideations, self-harm, or risk of harm to others, but PTSD patients should have a personalized safety plan that identifies triggers that may cause flashbacks or associations. Patients who become distressed by loud noises may need a quieter room or environment during hospitalization. The nurse plays a key role as a patient educator and has the responsibility of teaching patients about PTSD symptoms, triggers, and coping strategies. The nurse should also explain the purpose and intent of psychotherapy and medications, while providing compassionate care to their patients. Additional education should be provided about the interdisciplinary teams, their roles, and the approach to care coordination for treating the patient's PTSD. There are several key roles that physicians play when treating patients with PTSD. The primary role is recognizing the symptoms of PTSD and referring the patients to the appropriate teams to create a multidisciplinary approach for treating the PTSD. Primary care physicians would manage care coordination to establish patients with psychiatrists, psychologists, social workers, nurses, occupational therapists, and/or physical therapists. Additionally, the primary care physician would evaluate the patient for effective responses to therapy. The holistic care approach would address psychological, social, and sometimes physical aspects of PTSD, but it is important to note that consistent, timely interventions are provided throughout a personalized care plan. This can ensure that the patient has improved outcomes. One of the most important providers in treating PTSD is the psychosocial therapist who will provide cognitive behavioral therapy and exposure therapies. Whether in a private session or a group setting, therapies need to be ongoing and maintained to improve the patient's treatment effectiveness. Patient compliance is key, and a multidisciplinary approach to therapy will provide the patient the best outcomes. Patient encouragement should be provided with all members of the healthcare team. While there are minimal pharmacological treatment options when managing PTSD, symptoms can be improved using antidepressants and SSRIs, which pharmacists can help to support. It is important that the patient works closely with their doctor to monitor the effectiveness of medications that are prescribed. The pharmacist also has a duty to work with the patient's psychological team to determine the appropriate medications that are effective for the patient. One of the biggest challenges with PTSD is that there are minimal physical symptoms, which often delay patients from seeking care. PTSD manifests itself months or years after a traumatic event, and patients often present with overlapping social or medical barriers. Symptoms may be misinterpreted as depression, anxiety, ADHD, or personality disorders. Patients often underreport symptoms due to shame, stigma, or fear of judgment. Generally, PTSD symptoms are grouped into four types: intrusive memories, avoidance, negative changes in thinking and mood, and changes in physical and emotional reactions. Symptoms can vary over time or vary from person to person. PTSD symptoms can vary in severity depending on triggers or stressors that patients experience, and patients don't often seek help until they have difficulties getting their life back under control. With the help of medical professionals, individuals experiencing PTSD can get their life back under control. The treatment of this mental health condition combines evidence based psychotherapy, sometimes with medication, to reduce symptoms and improve daily functioning. Cognitive behavioral therapy and exposure therapy are used to restore quality of life, but disease management is very individualized, with therapy types, duration, and intensity tailored to the patient's needs. The American Psychological Association states that most cognitive behavioral therapy sessions are delivered over 12 to 16 sessions, individually or in groups, and that early intervention and professional guidance are crucial for effective results. Upon receiving treatment, patients with PTSD will have learned effective coping strategies and techniques to manage their disease. I've had my own experiences with watching a loved one suffer through PTSD, and this has inspired me to learn more about the topic and to share it with you through this presentation. I have learned that the key to successful treatment begins with patients feeling safe enough to seek support from medical professionals and engage in care. Trauma-informed nursing practices plays a central role in creating that safety. Nurses are often the first point of contact, and our ability to recognize symptoms, respond with empathy, and provide evidence-based interventions can profoundly influence a patient's willingness to participate in treatment. Through this project, I gained a deeper understanding of how PTSD affects individuals across physical, emotional, cultural, and geographical dimensions. I also learned how essential interdisciplinary collaboration is. As I move forward in my nursing career, I will carry these lessons with me, and I will strive to deliver trauma-informed care. My hope is that by better understanding PTSD, I can contribute to a healthcare environment where patients feel seen, heard, and supported through their healing journey. My name is Nicholas Andrade with Nightingale College, and this has been my presentation on PTSD.